The primary goal of risk adjustment coding is to A. Increase reimbursement for all diagnoses. B. Ensure accurate prediction of healthcare resource utilization. C. Focus on only chronic conditions. D. Eliminate the need for provider documentation. Answer B. Risk adjustment coding helps predict healthcare costs by accurately capturing patients' disease burdens through properly coded diagnoses. A patient with type 2 diabetes and peripheral angiopathy without gangrene should be coded as A. E11.9 only. B. E11.51. C. E11.65. D. I73.9. Answer B. ICD-10-CM code E11.51 reflects type 2 diabetes mellitus with diabetic peripheral angiopathy without gangrene, capturing both the condition and complication. Which documentation is essential for validating a hierarchical condition category, HCC? A. Diagnosis list from prior year. B. Provider's face-to-face encounter note with meet elements. C. Nursing triage form. D. Patient's insurance card. Answer B. HCCs must be supported by current year provider documentation containing meet, monitor, evaluate, assess, treat elements. When a provider documents CHF, the coder must A. Code unspecified heart failure. B. Query for systolic/diastolic type if not stated. C. Assume it's chronic. D. Report only if treated during the visit. Answer B. Congestive heart failure, CHF, must be specified as systolic, diastolic, or combined. Querying ensures accurate HCC mapping. A chronic condition is considered active if A. It is mentioned in the past medical history. B. It was treated within the last 2 years. C. It is currently monitored or impacts care. D. It appears on a lab report only. Answer C. Conditions being monitored, evaluated, or influencing current care are considered active and must be coded for risk adjustment. Risk adjustment relies on which model for Medicare Advantage? A. CPT-RUC model. B. CMS-HCC model. C. CPT hierarchy model. D. EHR adjustment model. Answer B. The Centers for Medicare and Medicaid Services uses the CMS-HCC model for Medicare Advantage risk adjustment. The meet criteria does not include A. Monitor. B. Evaluate. C. Assess. D. Transmit. Answer D. MEET stands for monitor, evaluate, assess/address, and treat. Transmit is not part of the documentation requirement. Which condition requires a combination code for proper HCC capture? A. Hypertension and chronic kidney disease. B. Hyperlipidemia and diabetes. C. Osteoarthritis and gout. D. Anemia and hypertension. Answer A. Hypertension with CKD is reported using a combination code to reflect the relationship between the two conditions. A valid diagnosis for risk adjustment must come from A. A hospital bill. B. A provider with a face-to-face encounter. C. Patient self-report. D. Pharmacy claim only. Answer B. Only diagnoses documented by an approved provider during a face-to-face visit are valid for risk adjustment. Which provider type is acceptable for risk adjustment data submission? A. Registered nurse. B. Physician assistant under supervision. C. Medical assistant. D. Receptionist. Answer B. Risk adjustment accepts diagnoses from physicians, nurse practitioners, and PAs under physician supervision. A patient with COPD and chronic bronchitis should be coded as A. J44.9, B. J42, C. J44.0, D. J45.909. Answer: C. J44.0 represents chronic obstructive pulmonary disease with chronic bronchitis and maps to an HCC condition. Which documentation error can cause HCC loss? A. Abbreviations, B. Missing signature, C. Outdated date of service, D. All of the above. Answer: D. Abbreviations, unsigned notes, and missing or incorrect dates invalidate documentation for HCC submission. In risk adjustment, the risk score represents A. The number of claims processed, B. The predicted healthcare cost based on coded conditions, C. The accuracy of billing, D. The level of provider education. Answer: B. Risk scores estimate expected healthcare costs based on patients' coded health conditions and demographics. When a patient has multiple conditions in the same HCC category, the coder should A. Report all, B. Report the most severe, C. Code only one representative diagnosis, D. Omit the secondary conditions. Answer: C. Only the highest weighted diagnosis within a single HCC category is used for risk adjustment scoring. The best practice for chronic condition capture is to A. Code it once per year, B. Review and document it at every relevant encounter, C. Code only if medication changes, D. Rely on previous claims data. Answer: B. Chronic conditions must be reviewed and documented annually or at each relevant encounter to ensure accurate HCC capture. ICD-10-CM combination coding is designed to A. Decrease claim denials, B. Represent multiple related conditions in one code, C. Replace CPT codes, D. Simplify billing across specialties. Answer: B. Combination codes provide a single ICD-10-CM code that describes both the condition and its associated manifestation. Documentation of obesity requires A. Patient's weight only, B. BMI measurement and provider assessment, C. Diet plan documentation, D. Fitness history. Answer: B. For coding obesity, both BMI and a provider's clinical assessment are necessary for valid risk adjustment. A suspect condition in risk adjustment means A. A diagnosis the coder assumes, B. A potential condition flagged by analytics for provider review, C. A confirmed chronic disease, D. A non-reimbursable code. Answer: B. Suspect conditions are flagged by data analytics for provider validation and documentation during encounters. The HCC model updates: A. Every quarter, B. Annually, C. Every 3 years, D. As needed by payers. Answer: B. CMS updates the HCC model annually to reflect coding changes and healthcare utilization trends. The key difference between prospective and retrospective risk adjustment is A. The type of codes used, B. The timing of data capture and review, C. The involvement of patients, D. The use of CPT codes. Answer: B. Prospective models predict future costs using current data, while retrospective models analyze historical data for reimbursement accuracy.